Hello, Dr. Mary O'Connor. It's such an honor to have you here today. I want to welcome you to the Soul Aligned Self Care Podcast.
Tina, I'm just delighted to be with you and your podcast team.
Thank you. To get started, if you could just tell everyone a little bit about yourself and your background, that would be great.
I'm an orthopedic surgeon. I did my training at Mayo Clinic in Rochester, and then I went on staff at Mayo Clinic, Florida, where I was actually the first woman orthopedic surgeon in the whole Mayo system. And I've been the first woman in many orthopedic categories, many professional societies. And then I retired from Mayo in 2015 when I went to Yale to work on an integrated musculoskeletal center. And then in February of 21, I left Yale to co-found Vori Health, which is a startup. And we are a virtual first nationwide musculoskeletal medical practice. Our philosophy is that patients need a more holistic approach to their musculoskeletal conditions. And I'll translate that's like spine and orthopedic problems,
Okay.
because there's a lot of inappropriate surgery that happens. And we know that we can help people get better without an operation if they're given the right care.
I agree with that. I'm a big runner, and in the running community, I see a lot of surgeries that happen very quickly before there's anything else tried beforehand to avoid the surgery. Like something as simple as weight loss, you know? So I see that a lot. I can imagine that you run into that quite often.
Correct. And just along that line, we know that women have more weight problems than men, and particularly individuals of color have a higher rate of being overweight and obese. And while we have these new weight loss drugs that have come onto the market that can be very helpful, there's a
Mhm.
couple really important things about these drugs. One is that when you lose the weight, you will typically lose lean muscle mass as well.
Mhm.
So anybody taking these drugs has to also focus on exercise and maintaining lean body mass, meaning muscle.
Mhm.
Number two, if you don't change your lifestyle when you stop the medicine, most patients gain the weight back.
Mm,
So it's
yes.
this is why supporting patients in a different way that really helps them address lifestyle issues that are impacting their health. And for us, it's musculoskeletal health, so back pain, knee pain, etc., is so important.
Yeah, there's so many different questions that I want to ask you because I feel like women don't really get the care that they need in general. They get kind of pushed aside quite often, like and prescribed almost anti-anxiety medicine for almost anything that they're experiencing or birth control. And at the same time, also as women are going into menopause, there's so many different changes that are going on in their bodies. Um, it's like you don't even know what direction to look in or what to focus on. It's like we're losing our muscle mass. We have to learn how to take care of our bones. And then at the same time, we're losing very important hormones that support our bodies. And we're dealing with like chronic inflammation and all these kinds of things. And it's almost like you have a brand new body every single day. And so overall, maybe you could talk about what can women do to really support their health and advocate for themselves when it comes to finding a doctor that's really going to listen to them and put their care first.
Oh, this is like the fantastic the question for women, right?
Yeah. Yeah.
So I'll start with a shameless plug for the book that I co-authored with a woman named Canwall Hawk, who's a medical anthropologist. And the book is called Taking Care of You, The Empowered Woman's Guide to Better Health. You can Google it, find it on Amazon. And we wrote the book with 111 women contributors. So
Wow.
expert physicians and a few other clinical types to really give the everyday woman the knowledge that will help her advocate for herself in a more effective way with her healthcare team. And we focused the book on kind of current state of medical care, like should Google be your first responder and how to find the right doctor. And then we go into 55 common clinical conditions, which are I'll call it the non-bikini areas. Because
Okay.
here's one of the other problems, Tina. Women's health has focused on, and not that this isn't important, right? Women's health has traditionally focused on breast cancer and reproductive issues.
Mm-hmm.
Okay. But that's just a portion of what impacts us as women. We get knee arthritis at a much higher rate than men. And as an orthopedic surgeon, this was one of my particular clinical areas.
Mm-hmm.
So like, why don't we understand more about that? I'm one of the few researchers that investigated this, and we found true sex differences in the tissue of arthritic knees of females compared to males. So, okay, so then what are we going to do about that? So this is totally under researched. It's underfunded. The the point is that women are not little men,
Mm-hmm.
and females are not little males.
Yes.
Okay. And so in our 55 common clinical conditions, which range from, anterior cruciate ligament tears to low back pain to heart disease to depression to migraines, etc., we talk about, what is the condition? What causes it? Can it be prevented? How is it treated? How does it impact women differently than men?
Mm-hmm.
Because almost all conditions are different in women than in men.
Yes. Yeah.
And some of those reasons why they're different can be sex-based, meaning biologically driven. Some of it could be gender-driven, meaning more societal influence of how females are raised, in our society.
Mm-hmm.
And then finally, a list of questions that you can ask your healthcare team,
Oh,
which
that's cool.
which I think is actually the best part of each of those.
Mm-hmm.
And then we have the final section that is really about how women can take more control of their own health and their health behaviors and support other women. And I use the term be a health promoter.
Mm-hmm.
What can we individually do to promote not just our health, but the health of those around us?
Yeah, I think that the younger we can start doing this, the better. Like, I feel like, when you're getting into middle age, like I look at my healthcare and I'm like, I wish I knew this. I wish I knew this was going to happen so that I could have prepared myself for this. I wish I knew that I was going to lose most of my muscle mass. Like, I'm 55 now and I could feel it happening. I could see it happening because I'm a runner. And so I can actually see it happening. I'm like, I wish I knew this. Maybe if I knew this, I would have lifted weights more at certain times in my life. And so, like, just learning about the differences, like you said, between men and women. And am I correct to say that most medical studies, including studies done on pharmaceuticals, are done on men and not women?
That's correct. Now there's been improvement in that, because a decade or so ago, um, the basically the NIH said, okay, you have to start including women in clinical trials.
Yeah.
I know. It's just like
It's mind blowing.
it is mind blowing.
Yeah.
And their rationale, again, remember, we're in a very patriarchal society, and
Mm-hmm.
medicine in particular remains very hierarchical and patriarchal.
Mm-hmm.
So the rationale was, oh, women are so complicated. They have these menstrual periods and fluctuating hormones. And so we can't study women because there's all these other factors that could influence, we'll say, the drug.
Yeah.
Okay,
Yeah.
but when the drug goes to market, 50%, 51% of the population are
Yeah.
female.
Yeah.
And we know this is a problem because if you look at medications that are pulled off the market after FDA approval, after they've gone through every single bit of safety regulations, right?
Mm-hmm.
This majority are pulled off because of adverse side effects in women.
Interesting. I didn't know that. I
Yes,
didn't know that.
so we are still not I'd say we're still not doing a good enough job.
No, you have to really investigate for yourself. And then still then after investigating, it's hard because even if you read studies, studies can be manipulated in certain ways unless you know what you're really looking at, unless you're a doctor and you could tell the difference between a good study and a bad study. They could be manipulated in ways that show one thing or show another thing. And that's why there's so many contradictions. I recently learned about statins for women because when women go and move into menopause or when they're in perimenopause, their cholesterol goes really high a lot of times. And then they get prescribed statins, which will lower the cholesterol, but it does not decrease their risk for a heart attack at all. But in men, statins work very well to help reduce the risk of heart attack. And so it could be very misleading to a woman to be put on statins. And there's a lot of side effects from statins. So if they're not going to really help you in the long run, then why go on and, take another pill? And so that's just like one small example that I learned about that I was like, okay, there's probably a whole bunch more, just even the way a heart attack presents itself to a woman opposed to a man is different. And so I feel like I'm glad that things are starting to change, but all the women like right now, they have to really, really do their due diligence when they're looking into medications and treatment plans and things like that.
Absolutely. And it's just, it's so challenging because let's take the example of heart disease in women. We've known for a long time, I don't know, 15 years. It's been a long time that it's been clear that a heart attack in a woman can present clinically differently than a man. So the classic symptoms of I've got an elephant on my chest,
Hmm.
this huge pressure on my chest, or this huge pressure and pain going down my arm. Classic symptoms of a heart attack. Every medical student is taught this, right?
Hmm.
Women, which occurs because of blockage of the larger blood vessels in the heart. Women tend to get small blood vessel disease in the heart. So there are true biologic, sex-based differences in the way heart disease occurs in females compared to males.
Hmm.
So if you're a woman, you may not even be thinking that you could be having heart symptoms. And so then if you go in to see your doctor and nobody's aware or thinking about this, you will be underdiagnosed,
Hmm.
undertreated, and that's a problem. Now, women still get classic heart symptoms, heart attack symptoms as well, but they're more likely to get these other kinds of symptoms where they're thinking it's just indigestion or,
Hmm.
it's really not my heart. So
Yeah.
yes, and I mean, it's just so frustrating that we as a group have been so under researched for treatments that are effective for us.
Hmm. Almost like we're some kind of a new species or something that hasn't been around the whole time. Even things like the car airbags in the car, aren't suited for women. And a lot of the injuries in car accidents come from these actual airbags when it comes to women because they're designed to protect men. Now that's changing. I know that that's changing, but it's kind of mind blowing when you think about all these all these things where women have to live inside a world that's designed and meant to support mostly men for the most part.
And that's because, just to call it out, we've been, second class citizens basically.
Yeah.
And that's not okay.
No, that's not okay. No, that's why I love talking about these topics. Another thing that I wanted to ask you, because I know I read part of your bio and it talked about hip fractures and stuff like that. And I think that's something a lot of women know as they get older and they move into like perimenopause and menopause is, you know, keeping our bones strong, and there's so many discrepancies in what you're supposed to do. Like, should I take calcium and should I not take calcium? Should I take vitamin D? Well, if you take vitamin D, you have to take K2. Should I do weight bearing exercise? Is this going to hurt me or is this going to harm me. I even have a very good friend of mine who's in her 70s, and I told her that she needs to lift weights and to keep her mobility, keep herself strong. And she's like, "No, I'm going to hurt myself if I lift heavy weights." I'm like, "No, you're not. Like, start small, work your way up." So like, there's so many different things. And I learned this morning. I was listening to a podcast. It was the Mel Robbins podcast, and she had a menopause specialist on there, a doctor, OBGYN, and she said that when a woman breaks her hip or has a hip fracture in her mid to late 60s, that it increases her chance of death in the next year by 65% if she has surgery, and 78% or something if she doesn't have surgery. And to me, I was like, what? Like, is that something that's true?
I don't know those specific statistics on the death rate for a woman in her 60s, but this is
Hmm.
such a critical topic for your podcast audience. And
Hmm.
and so I'm going to give you the story and the important nuggets on this.
Okay.
So fragility fractures, which is the term that we use in medicine to describe a typical hip fracture, meaning a fracture that happens with very low energy. It's not like you're in a car accident and your hip is broken. Okay. So
Hmm.
hip fractures occur because our bones get weaker as we age. And in women in particular, after menopause, the weakness of the bone accelerates. So part of the key is having bones that are strong enough that um, that you don't live so long, right? That you fracture before you die.
Hmm.
Just to be blunt, this is all
Yeah.
about how long you're going to live versus how the rate of decline of your bone strength. So what do we need to do? First, we need to build strong bones in young girls because everyone has a peak bone mass. Our peak bone mass occurs in our early 20s.
Oh my goodness.
Okay. So, right. So it's very important for our daughters, right, that they're involved in athletics, that they're building that strong peak bone mass. Boys, young men, have a higher peak bone mass than girls and young women because of the effect of maleness and supplemented by testosterone. So men start with they have stronger bones than women.
Hmm.
So they have further to fall before they fracture their hip.
Hmm.
And we see a very significant age difference in when older people fracture their hips. Women fracture their hips about 10 years younger than men. So
Wow.
men will fracture their hips too. It
Hmm.
just takes them longer to get to that fracture threshold. So we need to have strong bones when we're young. That's the first thing.
Yeah.
Or, and all hope is not lost for anybody that's listening to this saying, "Oh my God, I didn't
Yeah.
pay attention when I was young." No, you can still decrease your risk.
Hmm.
So then the key is weight bearing exercises, making sure that you're getting adequate vitamin D and calcium. Now, most people get plenty of calcium in their diet, particularly in the states where we love dairy, right?
Hmm.
People, there's a lot of dairy in our food. Um, but vitamin D is very important because you need vitamin D to absorb the calcium. And vitamin D is actually not a vitamin, it's a hormone. And
Yes.
there are receptors for vitamin D in our muscles. And we know that when we give people that are in nursing homes and long term care facilities vitamin D, they're at less risk of falling. So, I'm very big on vitamin D, which has kind of come under some, criticism lately that too many people are getting their vitamin D level checked, and medicine is making too much hoopla about low vitamin D. And I'm kind of like, I don't think so. I think
Yeah.
vitamin D is very important. So, making sure you're getting adequate vitamin D, weight bearing exercises, making sure you get enough calcium, which is usually not an issue for somebody. And
Hmm.
then when you get to menopause, right, the question is hormone replacement therapy.
Yes.
Now, this is another area where every single woman that lives long enough goes through menopause. And yet we still seem to have confusion about what is the best approach,
Hmm.
right? Because
A lot
remember,
of confusion.
right, a few years ago, there was a study that came out that said, well, hormones are going to increase your risk of breast cancer.
Yeah.
So all of a sudden, all menopausal women were told, oh, just forget it, deal with it. We're not
Hmm.
going to give you hormone replacement. Okay.
But that was a very specific hormone that a
Yes.
lot of people that do hormone replacement therapy do not like to use anymore, from what I understand,
Well,
right?
so now I'd say we've had some correction of that,
Hmm.
right? And now it would be okay, hormone replacement therapy is is good, it's okay. I mean, there may be some specific instances where somebody has a higher risk of breast cancer. And I mean, there's always outliers, right? But as a
Yeah,
general
exactly.
statement, people have the medical community has come back around to saying, okay, hormone replacement therapy for the woman in menopause, that's okay. However, they're also saying you only need that for a few years,
Hmm.
right? And I, I actually don't know that we have good data to say that that's true
Yeah.
because if women stay on estrogen longer, it helps keep their bones strong. So
Hmm.
again,
Among other things too. It
oh,
helps.
among other things.
Yeah, a lot. It helps a lot of things like heart disease, your risk of diabetes. Um, I'm trying to remember some of the other things. Oh, Alzheimer's lowers the
So
risk of Alzheimer's.
so you have to remember every cell in our body has a sex.
Hmm.
And the function of that cell is influenced by that sex, which goes beyond just the presence of estrogen and testosterone, because we tend to think of just estrogen or testosterone as driving all these sex differences, but that's absolutely not true. There's many things that are influenced by sex that's not just related to estrogen and testosterone. However, in this case, like your a woman's cells are used to having estrogen,
Hmm.
and now she doesn't have estrogen because she's gone through menopause. And I kind of look at that as, my cells aren't so happy. Maybe I
Yeah,
should give them back some
that's for
estrogen.
sure.
Yeah.
Yeah, that's an understatement. Yeah. So going back to some of the things that we could do for ourselves, when it comes to vitamin D, I keep hearing, and I'm not sure why this is, that you should take vitamin D3 with K2. It's important to have vitamin K. Now, I don't know why that is. Maybe you could school me on that a little bit. Is that
Uh,
something that's true or?
I don't actually have a reference for why people have focused on K.
Hmm.
Vitamin D3 is the best form of vitamin D to take.
Hmm.
And it's so easy to take. I have, little gel caps, and vitamin D goes by international units, not milligrams.
Hmm.
And I just take 1,000 international units pretty much every day, or 5 days a week. And
Yeah.
it's very hard to overdose on vitamin K. I'm sorry, on vitamin D.
Yeah.
So an easy thing is go out to go out to your vitamin shop, wherever you shop for your vitamins, and get yourself some vitamin D3,
Hmm.
and that's a good thing, because
Yeah.
most of us don't get it. The better way to get vitamin D is through natural exposure, meaning being out in the sun.
Hmm.
Okay, because that's how God actually designed us to get vitamin D. Vitamin D does not occur commonly in most food. That's why you see milk was enriched with vitamin D.
Yeah.
Okay, but when we get older, the lipid layer underneath our skin thins, which is, our skin isn't as nice.
Hmm.
That lipid layer is what the ultraviolet rays of the sun interacts with to actually make the vitamin D precursor. So the whole point is, as we get older, it's harder for us to naturally make vitamin D.
Hmm.
And if we live in a northern climate, you could run around the streets of Boston naked in
Yeah.
the winter, and you will not make any vitamin D precursor,
Yeah.
because the strength of the ultraviolet rays of the sun are not strong enough to convert the lipid layer under your skin to make the vitamin D precursor.
Yeah, and a lot of us, when we're going outside, we're protecting ourselves from the sun. We're constantly told to protect ourselves from the sun. And I mean, I could validate this. I'm in New York, and not in the winter so much, but in the summer months, I'm a gardener, so I am outside and I'm a runner. So I'm constantly getting a lot of sun, a lot of sun. And my vitamin D levels are always low. They always seem to be low. So I have to supplement with vitamin D. And I think it's very important to get that checked to know that, you know?
I agree. But even in New York, except for the summertime, the strength of the ultraviolet rays are not going to be strong enough to help you make vitamin D.
Hmm.
In the summertime, I mean, if you're fair-skinned, I'm fair-skinned. I have to sunscreen or I will sunburn.
Oh, yeah. Yeah.
So that blocks
Yeah.
the conversion of vitamin D.
Exactly. So, um, to finish up this interview, I would like to just ask you, how can people connect with you best? And like, how could they learn more about health disparities, which is your business? And I know you already talked about your book, and we'll put the links to your book in the show notes, but tell me more about health disparities.
Well, before we do that, I would just encourage everyone. We have a website called 1millionmorewomen.org,
Okay.
one with the number, the numeral one. And the purpose of this website is really to have women share their stories about their
Okay.
health experience. So I would ask anybody that's interested, go on. I mean, we keep the stories anonymous. We're not, sharing your name or identity, but it's really to try and start this movement of 1 million more women receiving more equitable health care.
This is so, I like that. This is really cool. We'll put that in the show notes also, um, so that people could, I think it's really important to share stories, because the more we share stories, the more we realize that we're all in the same boat and we're not alone and we're not the only ones experiencing all the things that we're experiencing. So I love that. And I'm definitely going to check that out. Um, is there anything else, that you would like to
Sure.
say to the listeners?
I chair a national nonprofit multi-stakeholder coalition called Movement is Life.
Mhm.
We're focused on addressing health disparities, particularly in the musculoskeletal space. And we have a fantastic annual summit.
Mhm.
This year, actually, it will be in Atlanta, Georgia. We oftentimes have it in Washington, D.C., but we're going to Atlanta this year, November 14th and 15th. You can go to the website, which is movementislifecommunity.org.
Okay.
And I'll send you the link. You could put that in the show
Yeah.
notes too. And our website, we have lots of information there. And anybody that's really interested in the health equity space, it's an amazing meeting. I would say very unique and one like you've never experienced before. So I would encourage people to join us.
Okay, that's so many great resources. I want to thank you for everything that we talked about, all your knowledge, and all of these resources. Thank you so much for coming on the Soul Line Self Care Podcast. I really appreciate it.
Tina, it's my pleasure. And, just wishing all the women that are listening or anyone who's listening, good health and the and encouraging them to basically be unafraid to advocate for their own healthcare needs.
Absolutely. I can't think of a better way to end this podcast. Thank you so
Okay.
much.
Thank you.